Morning, everybody. My name is Andrew Berkeley, and I'm the Chief of Innovation at Perimeter Medical. I'm also one of the co-founders. And today we're here to get the patient perspective on an important peer-reviewed article published in the American Journal of Surgery by researchers from Harvard Medical School. The paper addresses the growing problem of repeat surgeries in breast cancer patients who have lumpectomies or breast conserving surgery. About 20% of women who have lumpectomies have to return for follow-on surgery because of residual cancer that could not be seen in real time in the OR during the first surgery. These researchers detail the emotional, financial, and cosmetic impacts of repeat surgeries, which can be incredibly distressful for patients. Today I am joined by Jennifer Douglas, author, breast cancer survivor, and patient advocate to discuss this paper. Good morning, Jennifer.
Good morning. Thank you for having me here today.
Today, we'd like to get into discussing a very important subject for all of your listeners and anybody related to breast cancer, and that is, the impact of having a second surgery, which we know in the United States, about 20% of women who have breast cancer surgery will have to come back for a second surgery. So, as a breast cancer patient yourself or previous, if you could just introduce yourself and give some background as to how we ended up on this conversation.
Sure. In 2019, I was diagnosed with stage 0 DCIS after my second annual mammogram. It was small, and initially my surgeon recommended that I have a lumpectomy or breast conserving surgery. And I'm extremely grateful that my surgeon was able to remove my breast cancer the first time I had one surgery. But later, I actually found out that not all women have the same experience. While I knew how important it was to get the cancer out with a rim of healthy tissue, they call that a margin, I didn't realize how common it was for women to need to go back in for a re-excision or a second surgery.
Yeah, so when did you become aware of that, need for to get clear margins, and how did you discover that through your journey?
Well, I'm a bit of a researcher, so as soon as I found out that I had breast cancer, I started looking at what my options were. And during that research, I found out that, for my particular type of cancer, they did need to get 2 millimeters of healthy tissue out. And so that was something that I was really hoping that my surgeon would be able to do. And I had some conversations with my surgeon, and he expressed a lot of confidence in his breast conserving surgeries, how many he did, and how confident he was that I was going to be happy with the cosmetic results after my surgery.
And then after your surgery, did the doctor communicate with you about the margins and how he achieved getting clean margins?
Yeah, so it actually went in two phases. Phase one was my surgeon actually called me the next day he was at the hospital. It was a few days after my surgery, and he had a few minutes in between surgeries. And he said, "Hey, Jennifer, I just wanted to let you know that I was able to get clean margins from your surgery. So we'll discuss your pathology when I get back." When you have your follow-up appointment with me, but I wanted to let you know that I got clean margins. And that was a big sigh of relief for me when I got that call. And I'm so grateful he took the time in between his other work to give me that call. That was really meaningful for me, just to hear his voice and to be able to share that moment with him. Later, we had our follow-up surgical appointment, and I was able to get a copy of my pathology report. And in between my surgical meeting and my oncology meeting, I actually started reading through my pathology report, and I found something that was startling. The first specimen he got out of my DCIS didn't have 2 millimeter margins. And I circled that on my pathology report. And I said, how did he possibly get clean margins? But then I kept reading, and he had actually taken a second sample after that first one and was able to get those clean margins. And I had no idea my surgeon was using techniques in the middle of the operating room to check my margins. If he hadn't, I would have needed a second surgery.
Yeah, and I think that's the position a lot of, that 20% that we spoke about earlier find themselves in, where unfortunately some of the tools and techniques and technologies are not available to some surgeons in the United States and all over the world. And that second piece of tissue that needs to be taken during the operation is not taken, and therefore um, the pathology finds that those margins are too close, and then that patient has to come back for the second surgery. So it's really great to hear that your surgeon had tools available to them to be able to find intraoperatively if your margins were close, and take action on that. So that leads us to a journal and a paper that you and I are both familiar with. It came out of Beth Israel, Harvard Medical School, from Dr. Ted James and his colleagues over there. And it looks at the life factors of the impact factors of re-excisions and second surgeries on breast conservation surgery patients. And one of the things that really stood out to me is that the emotional well-being was really heavily negatively impacted for patients who had to come back for a second surgery, rising from 17% up to 35% of having a negative emotional well-being after a re-excision. Now, these numbers show us that patients are suffering, but from your perspective as a breast cancer patient, can you just get into describing what some of those emotions may be and how they affect your day-to-day life and your family's life?
Yeah, so what's interesting about the data is it really reflects what I see in some of the patient support groups that I lead. We put a lot of emotional energy organizing our life, getting ready for surgery, getting our mind and our emotions ready to go through what surgery is. And for some patients like myself, this is our first surgery. We've never gone into a surgery ever before. And so we're nervous about the surgery, and then we finally get through it. We have this relief. Okay, we got through it, but then we have to do the whole thing again. And it's a setback. We're frustrated, we're anxious. It took so much to get to that first surgery, and we're depleted, and we need to move through and go through another one. And it's sad, it's disappointing, and we'll do it because we know it's the right thing to do to get the cancer out, but it's really hard. And I see those emotions, the tears, the frustration, when I talk to patients, when I talk to them on the phone, when they send me messages. It's real. The distress is real, and it lasts. When I hear patients talk to me even years after, they recall what it was like to get that second piece of information that they needed a new surgery. It hits us emotionally very difficult.
Definitely, that receiving that second phone call to say that we didn't get it all is, from years of speaking to surgeons, is a really difficult call to make. But I could only imagine what it would be like to be on the receiving end of that phone call. Another statistic that jumped off the page from the study was the patient satisfaction, which was about coming up to 80% for patients who had a lumpectomy, but it drops down to below 50%, 47%, in fact, for women who had to undergo a second surgery. And then a lot of those women, about 25% who come back for second surgeries, will actually have to convert to mastectomy, which, if you're a patient going in thinking that you're going to have a minimal procedure, to end up at the back end of it with a mastectomy must be incredibly traumatic, not just mentally, but physically. So I'd like to hear your thoughts on, what would be the thought process of a patient going through that journey from not just having to have a surgery, but potentially coming back and having to have a mastectomy.
Yeah, so what's interesting again is those statistics really reflect what I'm seeing and the real conversations I have. But I know so many decisions about our care, they're based in research. So seeing that there is such a drastic difference, I'll just tell a little bit about some of the what I've seen and the conversations I've had. We go through a lot to try to make the right decision. And both mastectomy and lumpectomy are valid choices. If we're being offered the choice, we can like, okay, we're going to pick one and they'll both remove the cancer. So a lot of us go through a lot of deep reflection, lots of conversations. We do the research, we really try to plan. And once we finally get to that decision that we wanted to make, we're like, okay, we've made the right decision, we've done it. But then when you find out you need another surgery, you doubt your entire decision-making process that got you to that surgery in the first place. And I think that's where we're seeing that's the patient perspective of like, I worked really hard to get to this decision, and now did I make a wrong decision? And there's getting the cancer out, we need surgery to get the cancer out. There is no right or wrong, but in the way we're making these decisions, they are huge. They are life altering. And sometimes when you make the choice or you need to convert to a mastectomy, that is really hard. With a lumpectomy, you're preserving your breast, you're preserving surgery, you're preserving sensation, feeling. A lot of us, we have real specific reasons why we chose a lumpectomy. And when we choose a different surgery rather than the one we had, that is hard on us. It is maybe now we're dealing with a reconstruction choice we didn't think we needed to make. Maybe we're now losing sensation in a breast. Maybe we decide, you know what, I cannot do this again. This was so hard. Maybe I opt for a double mastectomy. And I have had many conversations with patients who are like, I can't do this again. I can't wait for that call that they didn't get it all. So, and I can't do this again. So I need to do the double mastectomy for my well-being.
Yeah, there's so many layers there to unpack, right? You did touch on with another factor that was covered in the study was the negative impact on body image, which you touched on. But there's so many different layers to this. There's also, the financial implications. People who have careers and who have jobs. There's impact on families. A lot of women who have breast cancer have young families. And the impact that it has not just on them, but on their family and their support system around them. So it'd be interesting to hear some thoughts on that.
Yeah, so when we need to have that second surgery, we now need to take more time off work. Maybe we need to find more care for our children. It overall extends our time in treatment and delays our overall recovery. And sometimes, logistically, that can actually mean a lot of increased cost, maybe not for a second surgery, but also maybe it pushes that entire cancer treatment over the calendar year. And for patients in United States, sometimes that means you need to pay one deductible, get to your out-of-pocket max in one calendar year, and now you're still in treatment in January or February, but you've got to now come up with an entire out-of-pocket max again because it delayed everything that much longer. And that is a real financial hit for a lot of us. It's a cost. Those out-of-pocket maximums are a lot, and it really can present a financial hardship for us.
Yeah, exactly. And not everybody lives within driving distance of their care facility. So we hear of patients driving hours to get to their care. So there's just so many different levels here of additional cost and expenses that patients have to undergo. When we look at the conclusion of this study, it does emphasize the need for patient support and informed treatment decision making. They also highlight the importance of margin control, given the reported impact of patient outcomes of reoperations. So what they're looking towards is future research should focus on deeper exploration of patient experiences to ensure that the patient's perspectives continue to be central in shaping their breast cancer treatment. So what would you say to somebody who's entering into a situation like you for the first time, and how they can be part of that treatment decision making, and what needs they would have for patient support?
So I have quite a few thoughts about that. I'll keep them central to this topic. One is ask a lot of questions. As a patient, I really feel like the more questions we can ask about of our surgeons about how many breast conserving surgeries do you do? What is your re-excision rate? Are you able to use advanced techniques in the operating room to ensure that you're getting clean margins? Knowing to ask those questions. In fact, I didn't know to ask about my surgeon's re-excision rate, and I did much later after it didn't matter because he got it out the first time. But that is a question I'm always encouraging patients to ask. And what's interesting is when they come back to me and say, you know, my surgeon only does this number of lumpectomies. And a lot of times us in the patient rooms will say, well, maybe you could go find a specialist. Maybe you could find someone who does more, or, wow, that re-excision rate seems really high. Have you thought about getting a second opinion? And so in these support rooms, we're really trying to empower one another to ask the questions, to advocate for ourselves, because ultimately if we're the ones who are going through the treatments, and so asking questions, knowing what to ask, and are just a really key component. And then I guess on the flip side, to everyone out there who's working to solve this problem, so that no patient needs to come back into the operating room, I would say keep doing it, keep working. We need better techniques. We need advanced. Every patient should have access to a surgeon who can do what my surgeon did, which is see that they didn't get it all and go back while we're still under anesthesia, because it really matters to us. It impacts our well-being. It impacts the way we think about our treatment, even years beyond treatment.
Thank you. And then one last final question, which is kind of directed from my seat, is, what advice would you give to people like myself and my colleagues who are developing technologies to solve problems that we're talking, like what we're talking about today? How do you see a path forward for more patient interaction? Like, I speak to surgeons all the time, speaking to surgeons every week about our technology, but how do we build better awareness amongst the patient community and do that not just about the issue, but also what the potential solutions may be?
Yeah, I think having conversations like these where you're actually bringing a real patient on, a regular person, and talking about that impact of asking questions and patient empowerment. But also, I think that there's room to develop some patient-facing resources, as far as questions to ask about your surgeon, or empowering us to know more as we're going in. We're bombarded with so much information, but if we have some clear questions, maybe top three questions to ask your surgeon before you go into your breast conserving surgery. Simple resources like that could really help us know what to ask and feel like we can make a difference in our care.
Okay, thank you for sharing that. Okay, well, that concludes my questions. As you know, Perimeter's main focus is to provide technologies that improve outcomes for patients who are undergoing breast cancer surgery, and we're also doing some exploratory work in other tissue types like head and neck cancer and lung and melanoma. So being able to talk to somebody who is on the receiving end of our technology potentially is it's very refreshing, and it puts some real world perspective to all of the work that we're doing on a daily basis. So I'd like to thank you for your time and for sharing your experiences with me today.
Well, thank you for the work you're doing. It really matters to us, so we appreciate it.